Welcome, everybody. My name is Ray Ellen Cavey. I'm a member of the Academy and the Board of Directors here. And I'm thrilled about tonight's program because of all the subjects that people ask me about as a retired doctor. The number one question is about these drugs for treatment of obesity. So we have here two experts who are going to inform us. Dr. Sanan Saeed is an internist, and she has a special practice in health and wellness with a focus on obesity. And Maureen Geyser, also a member of our board of directors, is a pharmacist, and she's going to talk, and she has a master's in public health. And she's going to talk to us tonight about all the drugs that can be used for obesity. So we'll have time for questions afterwards and look forward to hearing from you about this talk and about any other talks you think would be useful for our Ask the Experts series. Thank you so much. Welcome.
Thank you. Thank you, and welcome to all of you, and thank you to the Academy for picking this topic as it is very relevant and inviting me here to speak on this, so thank you. So again, the title for today's talk is Weighing the Options, Navigating Weight Loss Myths, Meds, and Trends, and to really understand how these medications work and if they're the right treatment option for you. We really need to take a little step back and understand the context in which we as physicians choose to use medications and understanding a little bit of the basic physiology so we can figure out, okay, so I get that this medication works like this, and that means that these receptors are doing their job and it's a good thing. So putting all of that into context. So again, I have Vital Health Medical Care. I'm the physician and founder of Vital Health Medical Care. I'm board certified in internal medicine as well as obesity medicine. So over the next 30 to 40 minutes, we're just going to briefly overview the epidemiology of obesity and figure out, is it relevant? Is it prevalent? And trying to figure out the numbers behind it and the cost to society of obesity. And again, a quick superficial view of the pathophysiology just to make sure we understand a little bit about what parts of the brain and what parts of the gut are actually involved so we can better understand the medications and how they might work. Some of the numbers that we use as clinicians to help us guide and risk assess our patients to see what is their risk of developing hypertension or diabetes secondary to their weight. And then looking at some of the options that we have available to us. All you have to do is Google or be on Facebook or any type of, I think I dated myself by saying Facebook, but any type of social media, and you recognize that there are hundreds, if not thousands, of weight loss options that are presented to us these days. And that's why I feel this talk is so important and relevant, and why it's important to have a good understanding so we can make good decisions about what might be a good health and wellness and weight loss potential decision for us. And then looking into some of the evidence-based medicine studies that are out there that help us and inform us in obesity medicine, and as well as lifestyle medicine in making medical plans for our patients. My daughter put in the segues. She liked the curtain. That was her thing. There you go. So this is a self-reported map of the United States of the prevalence of obesity. All we really need to take home from this is, guess what? It's pretty prevalent. A lot in the Midwest and the South, we see above 40 to 50% of patients are dealing with obesity, overweight and obesity. And the rest of the country is not far behind, unfortunately. And the next map, again, just breaks it down just a little bit further into the demographic breakdown. So we look at non-Hispanic Blacks and Hispanics, as well as white demographics of the breakdown, again, of the obesity. And here we see, again, the Black population, mostly in the Midwest and Southeast, very high concentrations, and so the numbers are sometimes above that 50% threshold. And again, we see direct correlations with the prevalence of obesity with the incidence of diabetes, stroke, hypertension, etc. It's a small slide. I'm not sure if you can see all of the factors there, but really there's a lot going on. You can read through it, but pretty much anything and everything contributes to who we are and contributes to our overall health and contributes to our weight and BMI. And so the three major areas that we try to address when we see patients is recognizing their genetic background and recognizing is there an important role for genetics in weight. Usually, honestly, it's a very, very small and rare percentage where we can say it's really, dependent on genetics. Usually there are monogenetic diseases that are usually found in childhood. But for the most part, is there a family history of obesity and risk factors in the family that might be contributing? Also, if we look into the other socioeconomic components that contribute to obesity, access to food, access to education about medical decision-making and food choices, physical activity, management of stress, all of those factors contribute to our weight and our BMIs. Finally, there is a cultural component to it. There are certain cultures, certain demographics where different body sizes are appreciated differently. And so that also weighs into how people try to maintain their weight and their weight goals. Take-home point is there's a lot of factors contributing, and we try to hone in on the important ones when it comes to a conversation with our patients. This is a long definition of obesity, but to understand obesity is to really make sure we understand how complex it is. We, for many years, just thought, oh, calories in, calories out. So if I just ate less, I should lose the weight. And it must be some kind of shortfall on my part that I'm not able to lose the weight. And so what this definition recognizes is that it basically summarizes what the previous slide said. It's a multifactorial disease. Things that contribute are neurobehavioral components, where we look at fat tissue dysfunction, because our fat tissue is actually a hormone-producing organ. And so the hormones that it releases affects how our body responds to food and affects how our brains function. So we recognize that there is some degree of tissue dysfunction. We also recognize that there's a component of neurobehavioral disease, and again, that goes into social perceptions, that goes into personal perceptions of weight and how that affects our decision-making. And finally, looking at the consequences of obesity, which are either the mass effects of it from like osteoarthritis or sleep apnea, or the metabolic complications from it, like the high blood pressure, the diabetes, or stroke, etc. So it really looks at what are the causes of it and how our physiology affects it, and then what are the consequences of it. So it really recognizes that it's just not a calories in, calories out, simple kind of concept. This again takes home that point as well, where the calories in is equal to numerous factors where the calories are used. So when we look at your basal metabolic rate, that's the basic amount of energy that your body uses to function. And that's where a lot of the energy consumption happens. So what energy you're consuming, which is food, where does that energy get burned? Well, your brain uses energy to work. Your heart is pumping, your kidneys are filtering, your liver's doing its thing. Everyone's working together to make us work like pretty awesome machinery here. And when all of that works, that uses a lot of energy. And that's where our energy goes to use it to burn up that energy. Other areas are also physical exercise that we use, and also everyday activities of mobility, like getting up and lifting something up or moving or walking. It doesn't have to be just like 20 minutes at the gym or something. So it's the amount of energy that is released in the metabolic processes that are involved. So for example, your heart pumping and your gut metabolizing food, that consumes energy and can release that and uses heat and releases heat in that process. Okay. A very busy slide, okay? We don't need to understand every single line detail of it, okay? But some things I feel are important to get a superficial grasp of so we can understand why certain medications work. So we know Ozempic is a drug that's leading to a lot of success with weight loss, and it is a GLP-1 receptor agonist. So when we look at this here, we'll understand what does a GLP hormone do. And so that's why I'm going to actually look at 4 hormones in this picture. I don't know if there's a laser pointer on this. But basically, if we look at the brain, just below it, the hypothalamus is where our body finds its balance, its homeostatic state. And it balances by getting input from the body. So there's a hormone that tells you I'm hungry. There's a hormone that tells you I'm full. And it's that balance that's important. Those 2 hormones are ghrelin and leptin. So if you look at that picture of the stomach, the ghrelin is produced in the stomach, and that's basically the hunger hormone. It's telling your brain, hey, listen, I'm hungry, can you please eat? And when you're hungry, you don't have extra energy in the body, so it reduces your energy usage. It's like, wait up, feed me, I need energy. Ghrelin. The balance to that is the leptin, which is coming from farthest left on the screen, the adipose tissue. And our adipose tissue is that hormone-producing tissue. And the leptin is giving the other signal where it's saying, wait a second, we're done. You need to stop eating. We have all the energy that we need. They tell the brain that we're full, and they start increasing their energy usage because now we have energy. Okay, so it's just that balance. Those are the 2 hormones. The other 2 areas that I want to look at are the insulin. When they say food is medicine, truly food is medicine. The choices of what we put in our mouth dictate so much of what our gut looks like and what our hormones do. And so when we choose certain foods, that truly translates to how hormones react. For example, if we were to have a very simple carbohydrate like white bread, white pasta, or a simple like white flour pastry, that food, once consumed, gets into the bloodstream pretty quickly because it's simple. It's been a process to the point where all the layers of the wheat have been peeled off. And so there's nothing more for the gut to do. The gut's like, oh, you're already done being processed. Let me ship you into the blood. And so the rate at which the blood sugar goes up is very steep and quick and goes to a pretty high point. And when that happens, the insulin also follows with the same degree of rise as that sugar. And that's how that food choice affects it. And insulin is a hormone that controls and, lets the sugar get into the cells. But it also says, well, hold up, there's a lot of sugar right now. I need to store this as fat. So just by choosing one type of food, you've now translated that to a hormone level that's telling you to store it as fat. And the opposite occurs. So if we have, let's say, a whole grain or something that's whole wheat, that takes time to work its way through the gut, sometimes hours. And so the rate of blood sugar rise and the peak to which level it goes to is less. And so the peak of the insulin is less. And so we have less of a storage of fat. So just food is medicine, how we can see that translation. Sometimes the simplest things are the most relevant. And finally, or actually 2 areas, the GLP, which is like the superstar of the day, because that's what's put us on the map here, is that hormone that's coming from the gut. And that is a pretty fancy hormone. It does pretty amazing things. It's released from the gut, and it increases the secretion of insulin from the pancreas. And then it also decreases the breakdown of sugars from the liver. So it's basically saying, hey, we got a lot of food. We don't need any more sugar. Let's give the body the way to process it, right? But it also sends messages to our brain. So this is the gut-brain connection. And it's saying, hey, hypothalamus, I think we're good here. Slow down. We're getting full. I'm not hungry anymore. And then physiologically what it does is it slows the stomach from moving the food through the gut. So food usually gets pushed along the gut, through the stomach, through the gut, and it slows it down. So you have factors that are telling your brain, hey, I'm full. I don't need to eat anymore. The stomach is full. Everything is fine. Slow down. We don't need to eat anymore. And so if that's the effect of GLP, we can clearly understand some of the driving factors of why stimulating that hormone receptor can magnify that result. And that's why we see some of the results we see with weight loss in the GLP receptors. The one other thing that I'm going to throw in superficially here, because it's an up-and-coming area, is really looking at the gut microbiome. There's hundreds of trillions of organisms that live in our gut, and they all play a very important role in helping us to digest food. And it's not your genetics that really determines this, it's your environment. So less than 2% of your gut microbiome is genetically determined. So we all have pretty much the same thing. If we're living in North America, having a pretty typical North American diet, our gut microbiome is gonna look pretty similar. But what they found is certain organisms are much more prevalent in obesity, and that how we can control the growth of healthier microbiome by certain, again, food choices that help to let the microbiome grow, such as like kefir and sauerkraut, like fermented foods. They talk about prebiotics and probiotics. So a lot of that stuff affects it as well, and the data is still coming out. So hopefully I didn't lose anyone here, but I think it should hopefully help you understand the role of the medications a bit better. Again, these are numbers that we as clinicians use as cutoffs. Again, cutoffs they sound like they're set points and we have to use some number to gauge, but really this is a continuum. It's not like if your BMI is, 28 versus 27.8, there's a horribly different pathophysiology happening, right? So it's a continuum, and in this continuum, why is it important to set points? Because we notice as that BMI does go up, that your risk for developing metabolic complications and fat mass complication goes up. And really, as physicians, that's our driving goal. We get concerned because we want to prevent disease. We don't want you to show up at the hospital with diabetic complications or new onset diabetes or having a stroke. So what can we do before that happens? This is the heart of medicine, in my opinion, preventing the disease before it starts with education choices, and we'll go into all the pillars that we use, okay? One of the things, the caveats I do mention is BMI is used because most of the studies have used it as a cutoff to gauge risk for developing disease, but that does not take into consideration composition. So there could be a bodybuilder who's super duper muscular and they have a high BMI. Does that mean they're overweight necessarily? No, because your body mass index really just looks at your height and your weight, and they do a calculation based on that. When we go into percent body fat, that gives us a better gauge of where you are. So someone could look healthy or look thin, and I say that in air quotes, but then they have a very high percentage body fat, where still you have the same metabolic risk factors. So it's not about superficial appearances, it's about getting to your best health. And those are the metrics that we use. Just on a side note, because I am South Asian, of South Asian descent, from Toronto, had to throw that in. South Asians and Asians in general have a different BMI cutoff, actually, because they are found to have higher metabolic risk at a lower BMI. They tend to collect more adiposity in their midsection, which is abdominal waist circumference, which is one of the parameters for metabolic syndrome, and that tends to accumulate more in the Asian population. So that's just a caveat. So those numbers actually don't apply. They're actually lower. So like I mentioned previously, there's two components where obesity can have an effect. There's a physical effect of the weight itself, which can lead to diseases such as osteoarthritis or sleep apnea, like I mentioned. And then there's the metabolic parameters, which again, with visceral fat, we're concerned about because we're concerned about things that predispose you to high blood pressure, diabetes, stroke, etc. These are the parameters that we use that have correlated most closely with the development of these metabolic diseases. And those are the cutoffs. Again, lower in the Asian population, The waist circumference is lower, and the other parameters are the same. And this is just to compare the two things that I mentioned a couple of times already, which is the mass effect of obesity, whereas the metabolic effects of obesity. So moving on, if we have an idea of factors leading to obesity, and we recognize that obesity can lead to diseases both by virtue of mass as well as metabolic, what can we have, or what do we have as physicians in our toolbox to help with this? And so two organizations are very invested in this, the American Obesity Medicine Society as well as the American College of Lifestyle Medicine. And they have their pillars. And one of the things to remember is you need a comprehensive approach to weight loss to ensure that it's done safely and truly appropriately. And for that, following the pillars is pretty important. So if I just, if someone thinks, oh, I'm just going to take an injection and hopefully I'll be good to go, yeah, but there are other complications that can arise, first of all. And secondly, it may not be sustainable. And thirdly, it's not optimal because, again, the drive here is obviously weight loss, but it's weight loss and wellness has multiple parameters. That means health, energy, function, avoidance of disease. All of those are very important. In obesity medicine and lifestyle medicine, both start off with the same pillars. There's no one who's going to stand here and say, you can eat whatever the heck you want. You'll lose the weight on the meds. Yeah, you can do that. That's not the way to go. You want to be smart and thoughtful. Food is medicine. It's not cliche. It is medicine. The choices you make truly affect your biology. And so in both situations, nutrition is first and foremost. And nutrition really drives weight loss. 80% of the weight that we are is by virtue of the food choices we make. So some people say, oh, I'm just going to eat whatever and run to the gym and work out like crazy. That's really not the role for exercise. What we realize is the role of exercise is more to maintain weight loss. So we're not getting an easy deal all around. We're always going to have to make good choices and then also exercise to sustain those good choices and successes of the weight loss. And anyone who's tried diets or exercising and had experienced weight loss, it becomes easier to make those choices as you start to gain the benefits of good nutritional choices and exercise. The third pillar in obesity medicine is the role of medications, which is huge to kickstart the process, to help our patients overcome some of the challenges when the first two pillars just aren't coming together well enough, effectively enough, or in a timely way, such as to help them avoid those metabolic complications. The last pillar in obesity medicine is behavioral, which I kind of clump in with the 4 pillars that they have in lifestyle medicine, which is basically ensuring you're sleeping well, you have good social connections, you are able to manage your stress. So it's all about that good living, good health and wellness and lifestyle. So when that comes together, that's really where we come up with an optimal medical plan. So where do you go? This is just 1/1000th of what's out there. And I just bring it up to bring home the point that there are good components to any program generally that's out there. In my opinion, the only problem is they're not comprehensive. So you've got the PX90 and a guy who's like, I eat the pizzas and work out like crazy. That's one component, exercise. But it doesn't necessarily address the other factors. Noom tends to be more behaviorally driven when it comes to helping with food choices and monitoring our behaviors. But again, you need that comprehensive approach. And then you have the nutrition aspect, which is, the Jenny Craigs and the Weight Watchers. And again, very important, but again, only one of the 4 pillars. And my patients will know, I say that these pillars are like legs of a table, and each is equally important. And if one of them is not as effective or not, we're kind of missing out on one of them, what happens to that table? It's not as steady. And so it really is integral when coming up with a comprehensive plan is to address that. one of the things that, one of the studies that lifestyle medicine has really utilized to help in developing their guidelines was the Look Ahead study. It was actually initially done to look, it was based on the National Diabetes Prevention Program, and then they added on intensive lifestyle interventions. And when it comes to intensive lifestyle interventions, it's a fancy term, ILI, but it's basically what we talked about: a nutrition plan, an exercise plan, and a behavior plan. We got all of those components much more structured. And what they realized was that with these interventions, you can have significant success when it comes to weight loss and reducing the risk for metabolic complications. So this is a quick summary of how it was set up. I don't think I need to go into the details, rather than to say it was a nutritional program where they did do meal replacements initially to ensure that they were able to control the caloric intake for the first 4 months or so. Thereafter, they broke it down a little bit more, and so they allowed you to eat a little and then allowed you to do a couple of meal replacements. So they really wanted to control that. The exercise part was pretty easy. Exercise for 175 minutes a week, and then they give you 6 months to kind of get there, because not all of us can just start off with that number. So they give you a chance to get there, and then also behaviorally just logging what you're doing. And really what they've noticed was around a 7 to 8% average weight loss, which was sustained over time. And one of the biggest things was improved cardiometabolic parameters across the board. So hemoglobin A1C, lipid panels, blood sugars, blood pressures, all of that stuff looked better just with these lifestyle interventions. So again, food, exercise, these are all as effective as medications. We just need to know and have a comprehensive plan when approaching this. And initial success was very important in determining long-term success. So that's also something we have to keep in mind. So on the nutrition standpoint, they had the patients have around a 1,200 to 1,500 calorie diet, and that was based on the weight. And then, like I mentioned, they would do meal replacements for a while and then transition to a hybrid and then kind of do nutritional counseling to do a healthy diet thereafter. One of the things to remember is they did see it in their study as well, that there was metabolic adaptation, which basically I think we've all gone through at some point, where when you have around a 10% loss of body weight, your body then sends a signal to its brain and says, wait a second, we're losing weight. Don't use up all the energy. And so the amount of energy that we use to function, our basal metabolic rate, that goes down. So you're like, oh, great. Now my body's working against me. That's how it does it. And so learning the role of medications in that context, food choices, food timing, exercise, all of that kind of has to fall together to adjust to that metabolic adaptation. When it comes to fats, they stuck primarily to a Mediterranean composition of healthy fats, and that was outlined in the study initially. And protein. Protein was a big part of the weight loss plan. Protein is one of those underutilized. I guess now there's a bit more crave as keto came on, on the scene and such. But proteins do a wonderful job of appetite suppression. So if you have a big plate of pasta with just tomato sauce, you might be hungry. Even if it's a big plate, you might be hungry in a couple hours. And you're like, what is wrong with me? I just ate a ton of pasta. But you didn't get that protein in there. And so sometimes if you add in that protein, that can extend the duration of time during which you're full to 3 to 4 hours, sometimes even longer. So recognizing in the acute late weight loss phase, we usually want over 1 gram per kilogram of protein in our diet to help suppress appetite. Again, meds and all this stuff is great, but when our food choices are medicine and we can use them, that's where we really want to start with. Carbohydrates, the last point I want to make with this is understanding what glycemic index is and what glycemic load is, and that's basically what I've been talking about food choices. Glycemic index is how quickly that food hits your blood and causes your blood sugar to go up. So you want something with a lower glycemic index. Glycemic load is just your portion size. So am I going to have a lot of this or smaller amount? You want a lower glycemic index with a lower glycemic load generally. I'll just kind of skip through this really quickly. You probably want to be under the supervision of a clinician when you're doing very low calorie diets. We often do this with meal replacements, whereby we monitor very strictly how many calories the patient is having, so they're only having meal replacements. There are risks and complications that can happen in that process. So again, we check labs and we monitor our patients closely. So it's a very low carbohydrate diet basically, and it throws your body into ketosis, which basically means your body's not getting enough sugar from the food you're eating. So it starts to break down its own sugars, and that's the process of ketosis. I had spoken about the gut microbiome before, so I'll just quickly go over this again just to reinforce the point that this is an up-and-coming area in weight loss and recognizing the role of probiotics, prebiotics in maintaining a healthy gut flora. And basically, any type of movement is good. We don't have to all run marathons. Moving for at least 175 minutes a week, walking, swimming, whatever works for you. What we are creatures of habit. Get into good habits. That is the crux of all of this. Habit formation is sometimes what I work with my patients for the first couple of months. I don't care what you're doing. Just physically get up and protect that time and move. We will worry about the weight resistance and increasing weight resistance and muscle building and all of that stuff, but behavioral formation is the crux of what that is. Again, moderate intensity is around 175, 300 minutes a week if we're doing a lower intensity of mobility. And again, this is not oblivious to recognizing people's issues with joints. A lot of the patients do have issues with mobility. What exercises can they do to incorporate mobility into their lives? This is what we kind of established, because even sitting down where you are right now, there are numerous stretches and exercises that one can do to promote mobility, and that's really what the goal is. So the take-home point, I guess, is there are numerous health management options that are out there, and many of them are pretty good at what they do, whether it's the Jenny Craigs or the Weight Watchers or whatever. But you want to make sure that you hit all of the pillars that we talked about of nutrition, of exercise, recognizing if you need medications and the role of the medications, because that truly can be instrumental in progress, and looking at behavioral aspects of your life, which is pretty comprehensive. Connections, joy, stress management. Those are the parts that we want to focus in on. All right, well, thank you for listening to my portion.
Okay. Good evening. My name is Maureen Geiser. I am a pharmacist. I practice at the Anthony Jordan Health Center. I work for Highland Hospital. And I also have a Master of Public Health. So kind of got a mixed bag of experience. So, breaking the rules and putting it on the piano. All right. So let's get started on weight loss medications. First question might be, who's a candidate for a weight loss medication? If you look at the FDA guidelines, it's people who've been following a lifestyle modification plan, so diet, exercise, behavior modification, for 3 to 6 months without losing at least 5% of their initial body weight. And they have obesity, which in this scheme is defined as a BMI of 30 or greater, or they have overweight with a BMI of 27 or greater, along with at least one weight-related condition, and that could be cardiovascular problems, type 2 diabetes, high blood pressure, high cholesterol, obstructive sleep apnea. So again, these are follow along the FDA's guidelines for using these drugs. And this question kind of got answered, I think, I want to take a step back for a minute as a pharmacist and mention other medications. Sanine mentioned some of the psychiatric medications, antidepressants, antipsychotics, some of the insomnia medications, the beta blockers, some of the seizure medications are known to cause weight gain. So if you're having trouble losing weight or you've started a new medication, you're suddenly gaining a lot of weight, ask your provider or your pharmacist to take a look. And we can take a look at, do a med reconciliation and see if there is another alternative. Sometimes there's not. Sometimes a patient just has to be on drug X. It's the only thing there is. Unfortunately, it's weight positive. But sometimes there are alternatives, like Sinine said. If you're on metoprolol, let's switch you to carvedilol. They're both beta blockers. Carvedilol is a little bit easier in terms of preventing weight gain. Some other drugs would be long-term use of corticosteroids. That'd be like your prednisone. I've had patients who've been on even inhaled corticosteroids, the inhalers, who've had some weight issues. And some of the antiretrovirals can cause weight redistribution. It's not so much that it directly causes weight, but the weight tends to be in the trunk, and it's more central obesity instead of the arms and the legs. And that that's visceral fat, so it can become a problem. So again, ask your pharmacist, ask your provider, is there something else I can take? So, when should weight loss drugs not be used? The first thing I would say is pregnancy. There is definitely an increased risk of adverse maternal and fetal events in obesity. A woman becomes pregnant and she's obese, she's more likely to have problems. However, you have to have a certain moderate level of weight gain in order to have a healthy pregnancy. So that's something that's got to be balanced. So pregnant women should not take these drugs. If you're breastfeeding, again, that can become a problem. Some of the drugs we know get into the milk, and that could cause problems for the baby. Baby might not gain weight, or it could have other effects. Some of the drugs, we just don't know yet whether they pass into breast milk and the effect they would have. An allergy, a hypersensitivity. This is kind of an across-the-board precaution for any drug. If you're allergic to a medication or one of its ingredients, don't take it. And be mindful, though, because if you're allergic to one drug in a class, you could be allergic to other ones. There can be cross-reactivity. Probably if you're allergic to penicillin, you've been told don't take amoxicillin. It's that kind of an idea. The individual weight loss drugs also have specific precautions and warnings for each of them. Okay. Some of the considerations, which drug to choose. It depends on your weight loss goals and your unique needs. Are you looking to feel better? You're overweight, you just want to feel better, you maybe got a little arthritis in your knees. Or are you morbidly obese and you are having severe cardiac problems? You need to have a surgery imminently, and you need to get some weight off. Those are considerations. Other medical conditions, some drugs should not be used in certain medical conditions. If you have a bad heart, I'm not going to say you should take one of the stimulant drugs. Drug interactions, if you have to be on drug X, one of the weight loss drugs might not be a good choice for you. Insurance and cost is a big thing. I received a letter from Medicaid, a provider letter, within the past year. It said, we will not pay for weight loss drugs. Medicare has not been paying for them. I think it's changing, but they're currently not covering them widely. Other insurances, the coverage varies. And I did go through some of the formularies, the drug lists for some of the local insurances, Excelis, not to name names, MVP, a couple others. And they seem to follow the same rules when it comes to weight loss drugs. Most of them need prior authorization. They limit the number you can get, and they're going to have the highest copay. So, patient preference is another issue. Are you willing to inject yourself, or can you swallow pills? If you can't and you don't want to inject, we might have to look at other things. Drug availability is a huge thing right now. I'm sure you've seen if you open up Facebook, TikTok, Google, you're going to see ads popping up. Oh, we can, provide you with Ozempic. So there are definitely shortages of these, especially those newer ones. When to stop or change the drug. If the side effects are intolerable, don't take it. As far as I'm concerned, I'd rather be fat and happy than be throwing up or have intractable diarrhea or something. If you have really horrible side effects, it's not the drug for you. Talk to your doctor. Failure to lose at least 5% of your starting body weight after being on the full dose of the drug for 3 to 6 months. Some drugs just don't work for every person. So that's something to keep in mind. Okay. So, got to push the right button. So this is where I wanted to do the curtain transition, and I forgot to put it. So I should have had your daughter do it for me. So anyway, so the first, I'll just run through the older agents, and then we'll talk about the newer ones, because I know most people are interested in those. So the first class is the appetite suppressants. Most of the drugs in this class are stimulants. And I'm sure most of the people in this room remember Dexatrim. Yeah, that was actually it was kind of an allergy medicine, but it was a stimulant too. It was taken off the market because it was causing cardiovascular problems, strokes in young women. So it's off the market. It's off the human market. It's still on the veterinary market for a very specific reason. Anyway, so some of these are related to the amphetamines. So some may remember back in the day that you could get amphetamines sometimes without a prescription, and they weren't a controlled substance, and there was like the big thing to lose weight. They sometimes were called mother's little helpers. So they're sort of, yes, yeah, yep. My mother was given them just before her wedding so she could, lose a little weight for her wedding. I remember her telling me that. I'm like, okay. They don't do that, and in fact, you cannot prescribe them for weight loss anymore. That's kind of no, you can't do it. These are intended for short-term use, up to about 12 weeks. Honestly, I see them used a lot longer. But the most common one, I think, in this class is Phentermine, certainly what I have seen in my practices. And that was approved back in 1959, so been around a long time. It usually brings about some fairly moderate weight loss, depending on the dose and the duration. The average weight loss with Phentermine is about 7.7 pounds at 15 milligrams a day for 26 weeks, so obviously more than 12 weeks, or 11.7 pounds when you're on the 37.5 milligram dose daily for 14 weeks. These drugs are very inexpensive. If you take the generics, you're looking at $10 to $15 a month. And many of my current patients are Medicaid or Medicare recipients, but there are some who do pay out of pocket for this, for Phentermine. So we do dispense that. That's probably the only true weight loss drug I dispense. Some insurances do pay for it at Tier 1, which is the generic copay. Tolerance may develop after a while your weight plateaus. It seems like it stops working. They are controlled substances, just like the amphetamines, lower class, so that does add some extra prescribing rules. You'd want to avoid these for certain conditions, like I said earlier, if you have cardiovascular issues, if you have high blood pressure, hyperthyroidism, glaucoma, seizure disorders, agitation. Also, if you have a history of substance abuse, or if somebody you know is wanting to go on these, if they have a history of substance abuse, I would steer them away from that. Now, the remaining drugs that I'm going to talk about this is considered short-term therapy. The rest are long-term therapy, chronic therapy, because remember, obesity is a chronic disease. So anyway, the next one, some of you may remember this is an oldie but a goodie. 1999, Orlistat came out. So we went 40 years before they came out with a new one. It was sold as Xenical, 120 milligrams. That was the prescription version. It's currently the only true over-the-counter weight loss drug is Ally, which is also Orlistat, and 60 milligrams. Orlistat inhibits lipase, which is a enzyme in the gut that helps you absorb fat. So you block it, you can't absorb the fat. It reduces the fat absorption by about 30%. It's taken up to 3 times a day with fatty meals or fat-containing meals. Average weight loss is pretty modest. It's 7.6 pounds in a year with Xenical, so 123 times a day, or 4.4 pounds at 24 weeks with Ally. It's quite expensive. Generic and brand Orlistat prescription strength is like $850 a month. So it definitely requires a prior authorization. It definitely is going to be a higher tier copay if your insurance will cover it at all. And for the amount of good it does, I'm not sure that a lot of insurances are going to want to say, sure, we'll do that. Ally is not covered by insurances because it's over the counter. I did look on the websites for like Target, CVS, Rite Aid, whatever, and it's about $60 to $75 a month. So that's right out of your pocket. When you're on the Orlistat, you have to follow a low-fat diet. remember, it's blocking fat from being absorbed. So if you eat too much fat, where's that fat going to go? And that's going to cause some really bad GI side effects. I can talk to you about them privately later if you'd like to know. They're quite unpleasant. So it does block the absorption of some drugs. So that's where one of those drug interaction concerns comes in. It also blocks the absorption of fat-soluble vitamins, vitamin A, vitamin D, E, beta-carotene. So you have to take a daily vitamin supplement. That's just kind of not a big deal, but you have to do it. And it has to be several hours separate from your orlistat. It can cause some serious liver problems. It's been associated with gallstones and kidney stones. And it is available. Right now, it's not on the FDA shortage list, but the prescription stuff is on back order with the wholesaler we use where I work. Elido is available, according to the internet, at some of the local pharmacies. So if you really want to try it, it's out there. So then we went another 13 years till the next one came out. It's called Qsymia. This is a combination of phentermine, which is one of that appetite suppressant I mentioned, along with topiramate, which is a seizure medicine, anti-seizure medicine. It's also used for migraine prevention. I do see it used in addiction medicine too. We don't know exactly why this combination works, but there's some thought that the combination of the appetite suppressant with satiety enhancement, which kind of makes sense with the addiction providers that I'm seeing using it. Got to start off at a low dose and slowly go up. And that's really true of pretty much all the weight loss drugs, maybe not phentermine, but you want to go slow because you don't want to just run it right up. It can cause side effects. The average weight loss with Qsymia is 19 pounds at 1 year on the maximum dose. So that's not too bad. It is a little less expensive than Orlistat. It's about $250 a month. But again, prior authorization, higher copays, and quantity limits are usually applied. One thing I do see is the individual ingredients, phentermine plus the topiramate, prescribed separately. They're generic. They are often covered. Topiramate is covered by Medicare and Medicaid. You would probably have to pay for the phentermine, but it's cheap. The dosages don't match Qsymia, but we can make it work. Because topiramate, this probably doesn't apply to most people in the room, but it can cause fetal harm. So Qsymia actually has special requirements called a REMS program. And it can only be through certified pharmacies that you can get it. There's a lot of criteria. Women of childbearing age are encouraged to have a pregnancy test prior, plus once a month. It's not as strict as some drugs, but it's there. Oddly, generic topiramate or Topamax by itself for seizures does not have that REMS program. Right now, there are no current shortages. It's readily available. The ingredients are very easy to get. So, next is Contrave that came out a couple years later. This is a combination of naltrexone, which is an opioid blocker. We use it to treat alcohol use disorder and opioid dependence. And then bupropion, which is a antidepressant. It's been around since I was in pharmacy school. The first drug review I ever had to write at one of my internships was bupropion. So it's been around a long time. We also use it to treat help people quit smoking. They found that people who were on it didn't want to smoke as much, so it got marketed for that as well. Average weight loss was only about 9 pounds at 56 weeks, so a little over a year. Very expensive, up to $750 at the full dose. So again, prior authorization, third-tier copays, quantity limits, it's up there. As with Qsymia, I've seen the 2 separate ingredients prescribed. And they're both covered by Medicaid, Medicare. Generic copays. Again, not matching doses, but you can make it work. You have to cut your naltrexone tablets into quarters, but you can make it work. Contrave itself is readily available. There have been some spotty issues with bupropion, just certain strengths. Naltrexone is unfortunately now on the FDA shortage list. So those are the old school. Let's go to the new ones, the incretin mimetics. The first in this class for diabetes came out in 2005, so it's been around a while. Incretins are hormones, and the 2 we're concerned about are GLP-1 and GIP. They occur naturally in the gut, and they're secreted after you eat to regulate the blood sugar. They do this by stimulating insulin release, as Sanine said. They also inhibit glucagon, which is the hormone that tells the liver to release. We store sugar in our liver as starch. Glycogen, when it's like, okay, it's been like 6 hours since I ate, I'm starving, so I'm going to start kicking out glucagon. It's going to convert that starch and put it out as sugar, because your brain runs on glucose, so you have to have glucose. So it dials that down, and a lot of type 2 diabetics secrete glucagon inappropriately, so this helps with lowering their blood sugar. Natural incretins only last like 2 to 4 minutes in the body. So we can't really make them and then give them to you. You'd need to be on a pump all the time, putting it in your body. They're broken down by an enzyme called DPP4, and you can see it kind of in the lower left corner in the yellow of my my little graphic up there. Those DPP4s, there's actually a class of diabetic drugs that are DPP4 blockers. They're the gliptins, like Januvia, sitagliptin. And they're kind of being looked at for weight loss. They're one of those drugs, like if you're on a diabetes drug and it's causing weight gain, this might be one we would recommend, because they tend to be weight neutral or even weight negative. So that's just kind of like one of those nuggets you find out. Incretin-based medications mimic the activity of GLP-1 and GIP, but have been engineered to resist being broken down by that enzyme. So that's where the Ozempics and whatnot come in. So here again, I should have the curtains open. The GLP-1 receptor agonists, these were all developed for diabetes first, and then they found out, hey, people lose weight on them. So GLP-1 is glucagon-like peptide 1 receptor agonist. So the first one that weight loss-wise that came out is Saxenda, or liraglutide, and it's marketed as Victoza for diabetes. Then Wegovy came out, and that's semaglutide, which is the same as Ozempic, and that's the one that's always in the news. And a lot of the research that we're starting to see now is on semaglutide, because it's been around for a while. The GIP-GLP-1 receptor agonists, okay, this is a mouthful. Glucose-dependent insulinotropic polypeptide receptor agonist plus the glucagon-like peptide 1 receptor agonist. This is Zepbound, or tirzepatide. It's marketed as Mounjaro for diabetes. It's got a dual mechanism. It's getting on those GLP-1 receptors and stimulating those, and on the GIP receptor, so you get more bang for your buck. All of these are given by injection. They all have to be kept in the fridge. So if you're someone who travels a lot, that can be a consideration. So, okay, where did these come from? Exenatide, which was first marketed in 2005, it turns out is a synthetic version of a peptide, exenatine 4, that's found in Gila monster saliva. Who found that out? I don't know. But there are people who literally go around and they look at plants, animals, and whatever, and see if they they can work for medical reasons. Liraglutide and semaglutide, so the Saxenda and the Wegovy, are synthetic versions of human GLP-1. They were made with recombinant DNA technology. They're grown in big vats by yeast. You'd think they could grow more because it's yeast, but they don't, apparently. Tirzepatide is a synthetic version of GLP-1 and GIP, and I believe they are hooked together somehow in their synthesis. They're the dual agonists. If you look at the structure, the exenatide is about 50% identical to human GLP, but when you get to liraglutide, it's 97%. Semaglutide or Ozempic is 94%, which works, it works, right? Semaglutide works a little better even than liraglutide, but the ones from closer to the Gila monster tend to be more allergenic. You're more likely to have an allergic reaction, and they can be really bad allergic reactions. So anyway, but I had to put that in there because Ray Ellen, you told me I got to put the Gila monster in, so I did. So when it came out in one of my pharmacy journals, I'm like, oh my gosh, who'd have thunk? So anyway, how do they work? Sanine kind of touched on this a little bit. The GLP-1 receptors are found in the pancreas, brain, stomach, heart, blood vessels, the kidneys, the liver, the lungs, and probably other places. We don't know. We're finding out more every day. The GIP receptors are found in the pancreas, the gut, the brain, and in fat tissue. Fat is metabolically active. It is hormonally active. In the pancreas, these drugs stimulate secretion of insulin to help move sugar out of the bloodstream. In the stomach, they slow down how fast the food moves out. It's called delayed gastric emptying. And then you know, when your food's just sitting there, you feel full. So you might not want to eat more. In the brain, they act in areas that are involved in appetite regulation and satiety, as well as regulating your food intake. They have direct and indirect effects on other organs and tissues. It's not clear yet the role that plays in weight loss or in other conditions, but I think in the next 10 years, we're going to be seeing a lot more of these drugs for a lot of different things. And actually, when they're stopped, to answer your question, people do tend to regain weight. Maybe not 100% of it, but they do regain a significant part of the weight. So, okay, this is just a little like, okay, it's in the brain, central nervous system, the heart, the stomach, the pancreas. It's in other places too. So, some warnings and precautions. No drug is without side effects or issues. There can be very severe allergic reactions like anaphylaxis, like bee sting level, peanut allergic kid level, angioedema where your face and your mouth swells. They've occurred. It's twice as common with the drugs that are closer to Xanadin, closer to the Gila Monster versus the synthetic ones. But once you've had a severe reaction to one, I would never recommend taking another one, even if it's a different one, just because the reaction can be so severe. If you see the commercials on TV, you'll always hear that little voice at the end saying, if you have a history of thyroid cancer, there is a risk of thyroid C-cell tumors. When they were studying it, the animal models, there was an increased incidence of these tumors in rats, mice. So it's not clear if it was caused by the drug or not. So medullary thyroid cancer or other types of cancer relating to the thyroid, if you were taking them and you suddenly had some neck mass, you felt something in there, difficulty swallowing, breathing, persistent hoarseness, you're going to want to talk to your prescriber about that. Like I said, you don't use these in pregnancy. There were some fetal or abnormalities in the animal models, low birth weights, miscarriages, not in all of them, but some of them. A pregnancy registry has been started for Wegovy, and there's one plan for Zepbound for women who have taken these, have been exposed to them during pregnancy. We just don't know, but if it can happen in a mouse, it potentially can happen in another mammal. So I think that's the idea behind it. There's some risk of pancreatitis. We know they work in the pancreas, so if you were to get sudden back pain, abdominal pain, you're going to want to report that. Risk of gallbladder disease. This seems to be more common. Some of them are indicated for kids age 12 to 17. Gallbladder disease is more common in pediatric patients. Gallstones can happen to anybody, though, on these, and substantial or rapid weight loss is a risk factor for gallstone. So if you start you have a French fry and you start having pain up here, it could be a gallstone. It's typically gallstone pain refers to your right shoulder. That's why I say that. There is a risk of acute kidney injury, as mentioned before. It's most common in patients who've had nausea, vomiting, diarrhea, which results in volume depletion, or in people who aren't drinking enough, you get dehydrated. Nausea, vomiting, diarrhea are side effects of these drugs. Recently, a warning came out about suicidal behavior and ideation with these drugs. That has been seen with other chronic weight loss drugs. It hasn't specifically been seen with these drugs, but I think it's just become like, okay, we don't know if it's from losing weight or if it's those drugs. Let's just be careful. And we do know that these drugs can have some psychological side effects. So, speaking of, most common, nausea, vomiting, diarrhea. Some people get constipated, headache, fatigue, abdominal pain and bloating, gas, dry mouth, injection site reactions. Some people do, they inject it and they'll have like a red welt. Some people will get swelling, and that can be a problem. I actually talked to a patient at some length yesterday. He used not one of the weight loss drugs, one of the that's indicated for diabetes, and he said, I always get this little bump, and I didn't get it. And we think that maybe his pen misfired. So I referred him to the company, but he's like, I always get it. So it can be as simple as like, I feel a pinch and I get a little bump. It can be, I've seen pictures of watches, so it can be all over the board. Less common but more potentially concerning side effects are increased heart rate, low blood pressure, anxiety, depression, insomnia. I brought up Ozempic face and Ozempic butt because it's all over the internet, or seems to be, I don't know. It's the loss of facial volume and the loss of fat. It results in a more gaunt appearance in the face and a wrinkly face and a saggy buttocks. And it's just, it would lose skin. And you lose weight really fast, it's going to happen. This also occurs in patients who have bariatric surgery. So rapid weight loss, you might get Ozempic face or you might get Ozempic butt. Buyer beware, I guess. So the first one, as I mentioned, is Saxenda. It was approved in 2014. This one is dosed every day. These all come in a pen, and that's a picture of the pen right there. Average weight loss was, again, all these start low, go slow, and work your way up. Average weight loss was 8.1 to 11.4 pounds at 56 weeks. I don't know why they picked that, not 52 weeks, but okay. The average cost is around $1,600 a month. It's pricey. If you got to pay for it, it's pricey. Prior authorization, the third tier copays, quantity limits, pretty common. These don't come with needles, so you also have to shell out $15 or $20 for a box of needles. On the shortage list right now. That's on the FDA shortage list. So I have never laid eyes on this. I do dispense a lot of Victoza, which is the diabetes version, but it is every day. Works well, but Wegovy, came out, was approved in 2021. This is Ozempic in diet form. It's dosed weekly, and all that monkeying with the molecule, that it's only 94% like the human, part of that is to make it so it lasts longer, and you can dose it once a week. Start low, go slow. It is dosed a little differently than Ozempic. The average weight loss was in the range of 22 to 27 pounds at a year. So a little bit better, 16, 25, give or take a month if you were taking it out of your own pocket. The same, prior authorization, tier 3, quantity limits, insurance issues. It comes in a 4-pack of pens, and the needles with these ones are attached, and they actually have a little cover over the end of it so you can't see it, because some people are very needle phobic. So some of them are set up like that. Also on the FDA shortage list. Last but not least is Zepbound. This is the dual action one. This was just approved in November. It had been out as Mounjaro for diabetes. It is also dosed weekly. Same kind of thing, start low, go slow. This one is actually dosed the same as Mounjaro, the diabetes version. Average weight loss for this one was 41 pounds in 1 year. So this is the big guns. It's actually only $1,280 a month, or for 28 days. Again, the same insurance issues apply. Comes in a 4-pack with the needles attached. It's got the cute little cover so you don't see the needle on the shortage list. So all of them are. So here's the scorecard. Tirzepatide is the big winner. On average, 21% weight loss. I don't know over what, I think it's over a year. But I'd have to go back and look at the actual article I got this from. Wegovy is next at about 15.5%. Then we go to the Qsymia, the phentermine topiramate, 9.7. Liglitide or Saxenda is a little bit lower, 6.4. Then the Orlistat at 6. And the side effects are so miserable. It's like, and then the bupropion naltrexone at 5.5. So for the expense of that one, it doesn't perform that well. So if you're going to take a pill right now, I would say the Qsymia or the combination of the two drugs. If you can get your insurance to pay for the injections, go for it. Okay, so the future. There is an oral semaglutide oral version of Ozempic, so to speak. It's called Rybelsus. It's sold for diabetes. It comes in low doses, 3, 7, and 14 milligrams a day to treat diabetes. There are studies ongoing right now with a 50 milligram dose for weight loss. Some of the early results suggest it works quite well. So that's going to be a blockbuster when that gets on the market. Rybelsus costs the same as Ozempic. So the company that makes it was smart. It's like, well, either one. A study was published last fall showing semaglutide, Wegovy, improved outcomes for patients who had obesity and a certain type of heart failure. So, we know that there's GLP receptors in the heart. Looks like it's doing something. In March, Wegovy actually got an indication. It's what the FDA calls it. An indication is what you can officially use it for. Doctors can use it off-label, but this is what officially they can use it for. To reduce the risk of major cardiovascular events. In the study that led to this, cardiovascular death, non-fatal heart attacks, and strokes were reduced by 20% in adults who had established cardiovascular disease and were either had obesity or overweight. So that was pretty huge. A study just came out on May 24th in patients with type 2 diabetes and chronic kidney disease. Patients on semaglutide were 24% less likely to have major kidney disease events like kidney failure or death, which is really the big side effect, I guess, or the big concern, or death from kidney complications, as compared to placebo. They were also 29% less likely to die from heart attacks and other cardiovascular events compared to placebo. And kidney disease is tough, especially diabetics with kidney disease. The heart disease usually kills them before their kidneys completely shut down. There was also a 20% less likelihood of dying from any cause. Because it was such a profound effect, they stopped the trial. And anybody who was on placebo was put on drug because it was just unethical to keep these people on placebo because it was just doing so much. Like I said, there's GLP receptors in a lot of different tissues. There was an article, it was in Nature, I think it might have been in the New York Times too recently, about its new superpowers in treating inflammation. That was the title of the article. They seem to reduce inflammation in various tissues. I know there are ongoing studies looking at Parkinson's and Alzheimer's because there's an inflammation component in those in the brain. I think over the next 10 years, we're going to see tons of these drugs. They're going to be like the statins were. They're just going to be, blow the doors off. And hopefully the price will come down so they are accessible to more people. So like I said, you go on the internet and you see all these ads like, hey, Joe's Pharmacy House. They will compound it and sell it often at deep discounts. When a pharmacist can compound products, say a drug is only available in a pill form and I need it for a child, I can compound it, grind it up, mix it with stuff, make it a liquid. I can't just make pills because they're already commercially available. However, when a drug goes on the shortage list, the FDA shortage list, pharmacists can prepare a compounded version of it that's essentially a copy. However, once it comes off the shortage list, we can't do that anymore. We're not supposed to. With semaglutide and tirzepatide being on the shortage list, many compounded versions are cropping up online, like I said. Discounted prices. Some of them you just need to you have a telemedicine visit with some doctor or prescriber somewhere who will say, sure, here's your prescription. I'm going to send it to Joe's Pharmacy House. Joe's going to ship it to you. So there may not be any follow-up. Any drug, if you're on a drug, prescription drug, even on over-the-counter, you should follow up with your prescriber, your healthcare provider, periodically, at least once a year. And certainly with these, because there are a lot of side effects. Know that the FDA does not review compounded medications specifically for safety, effectiveness, or quality. They're not going to go around to every single compounding pharmacist and check that. Some compounding pharmacists are legit. They're really trying hard to help people who need these drugs. With the big weight loss thing, a lot of the diabetic ones have been unavailable, and So my diabetic patients can't get their meds, and that's heartbreaking because some of them have done amazingly well on them. Some of my patients have gotten off of insulin because they've gone on to like Trulicity or Ozempic. So there is definitely a good element out there. Some of the other compounders, however, may not be so altruistic. Let's take a look at some of these. So these were just a few that I pulled off the internet. Some of the products have slight differences. They might add a little bit of vitamin B12 to it. So it's not an exact copy. So when it goes off the shortage list, they can say, oh, it's different. That gets them around these compounding rules. Some of the products have been compounded with tirzepatide and semaglutide. The stuff you get from the pharmacy is from legitimate sources, is the base. Drugs, like I said, are tinker toys. And a lot of times a salt is attached to them so it gets dissolved better, and there's chemical reasons for it. Some of these places are using semaglutide sodium or acetate, and those are considered for research purposes only, not for human use. And there are some states have actually banned it. Oddly, they were all in the South. I thought that was interesting. Like North Carolina, one of the Carolinas, West Virginia, Louisiana, and Mississippi. You'd think New York, with all our regulations, we would have been at the forefront of that, but no. So these salt forms, we don't know if they're safe. We don't know if they're effective, and there have been reports of harm. So counterfeit products have been found, for sure. There's no guarantee that the product was compounded following best practices and that it contains what it says, that it's the proper dose, it's safe, that it's not contaminated. Back in 2012, you may have heard about the New England Compounding Center. Methylprednisolone injection was on the shortage list, and they were making it, and it was contaminated. There were 794 illnesses and injuries, including 64 deaths. So my advice is do your homework as to who you're buying it from, and buyer beware. So, and lastly, what about supplements and herbal products? I do get asked about these sometimes, and keep in mind that a lot of medications come from plants, animals, minerals, digoxin for heart. The heart comes from foxglove, for instance. Natural products can act like drugs, and they can have side effects, and they can have drug interactions. So, and they can be serious. So they're not always as innocuous as they seem. Dietary supplements can be put on the market without FDA approval. So if I open Maureen's, herbal house, I can go out in my backyard, pick some stuff, make a pill out of it, make a capsule, and sell it to you and say, it does X, Y, Z. Supplements are not well regulated in the United States. I'm not a huge fan of them, as you can tell. If there is a problem, the FDA will investigate, but some of the weight loss supplements do contain diuretics, which is a water pill. They can contain laxatives. They can contain stimulants, including some that are actually banned in the U.S., like ephedra or sibutramine. These may not even show up on the label, so you may not know what's there. If you are going to take a supplement, I take turmeric. My orthopedics person said, it's great for your knees, so I take it. But I made sure to find one with the USP label on it. The USP, the NSF, or the consumer labs, they test these things and verify that they contain what they say. They're potent, whatever. They're safe. So always look, if you're going to get one, get that. I did look at a database, and there were 10 pages of weight loss drugs, and I'd click on it, it's like, off the U.S. market, off the U.S. market. The ones that we're still on, most of them contain stimulants like green coffee extract, green tea extract, and they rate them by whether they're effective or not, and most of them, on a scale of 1 to 10, the highest I saw was 5. And then I gave up because I couldn't go through all 10 pages because there were just too many. But one supplement I would bring to your attention is psyllium powder, good old Metamucil. They changed their labeling recently, I don't know when exactly, but it's called Metamucil 4-in-1 Fiber. And if you start reading it, well, first of all, it popped up in one of my pharmacy journals or something called Poor Man's Ozempic. So the package says it can help support appetite control, and you take a double dose. So instead of 1 spoonful in 8 ounces of water, you take 2. It says, control your appetite. The plant-based psyllium fiber in Metamucil helps curb your appetite so you feel less hungry between meals. So is it going to hurt you? Probably not, unless you're allergic to it or have, asthma and the powder's flying all over. It's not listed for like the gummies or the crackers or anything, just the powder. Again, with supplements, my advice is do your homework and buyer beware. I mentioned it on here. Memorial Sloan Kettering has a website called Search About Herbs. They have like 284 herbs on there. It's free for the public. You just, if you're like, I want to find out about green tea extract, go on that website and check. Or ask your pharmacist. I know we, through Highland and Strong, have access to the Natural Medicines database, and it's got tons and tons of stuff in there, and it's got a lot of information. So ask your pharmacist or ask your prescriber. It might be right for one person, but not right for another person, because you're an individual, unique individual who, it might not be right for you if you have cardiac problems, say. So again, caveat emptor, be careful, buyer beware. And lastly, I have this book called Quackery, and this was one of the pages in it. So it was bottled tapeworms. So losing weight has really come a long way. So with that, I thank you very much, and we'll be happy to answer questions. Thank you.